Every year, about 500,000 people die in this country. Some of them receive very good care at the end of their lives, but others do not. Hospices, for example, have really shown how care can be given with excellence. But we know that a lot of people with a range of different diseases do not get that care, nor do they die where they would choose to die, and nor do they get all the services working together. That's why we've developed the end-of-life care strategy, and that's why it's so important that it is now rolled out across the country. And I am very keen to work with places like Weston to make sure that really becomes a reality. And I'm very impressed by what is being done here, particularly with regard to the locality registers, where I think you can be a leader setting the pace for the rest of the country.
John Bailey is a community palliative care nurse based in Weston-super-Mare. Today, John's visiting a patient called Molly, who's chosen to start thinking about how she'd like to be cared for as she reaches the end of her life.
Molly was very keen that she wanted to get her affairs in order, and when I was visiting her, we talked about advanced care planning and how we could assist her on trying to make plans to make it easier, making decisions when things became worse for her.
And he sort of said, well, I'll do an endoscopy, and if I can do another stent, I'll do it there and then, which they did.
Molly was diagnosed with carcinoma of the esophagus 6 months ago. Talking with John about the future is helping her to plan her care and prepare herself and her family should a crisis arise. She's making choices about the type of treatment and medication she would and wouldn't want, as well as considering where she might want to be cared for.
I've only one daughter. Unfortunately, lost her son 4 years ago, so it's all going to fall on her shoulders. With her eldest son, my grandson, he'll be a big help to her. But I want to get things down on paper, and I try and discuss it with her. She doesn't like discussing it. She finds it very, very difficult. But I find if I can discuss it with her, it'll take a lot of the worry off of her shoulders. She'll know she's doing what I want. And hopefully it'll help her come to terms with things a lot quicker.
Molly is just one of an increasing number of people who want to think about making plans for their future care. That is, having discussions and documenting the care they might want towards the end of life. This is really helpful not just for individual patients like Molly, but also for their families.
Prue had a similar experience. When her husband George was diagnosed with pulmonary fibrosis, the couple went through the planning process together.
We said we will discuss things and get things organised for our family. We will not put those under any stress. So we always used to plan things. So we planned what we wanted done when anything happens to us, because we didn't want to give any stress to the family. Because we'd planned things and we knew what was ahead. I mean, this is something that none of us can get away from, can we? We've all got to go sometime, and it's much better to plan what you want to do ahead, because I know now that I'm what I wanted to do, which I wouldn't have thought of if I hadn't sort of planned it out in the beginning with George.
And she had a great sense of humour.
Alan and his partner Hilary also spent time discussing her wishes together. They didn't go through formal paperwork, but they did talk about her care and about the future.
As time goes on, you obviously do have a lot to organise and get sorted. We actually sat down one night and we made a list of things that we needed to get sorted out. Knowing that, you know, when the time came, that apart from a quick phone call, I didn't have to worry about any of it. Was great, because I didn't have to go chasing around trying to organise stuff. It's much better to do it up front while you still can, because at the end of the day, as long as you're both able to talk about what's happening, then there's no reason not to get it sorted.
Being involved in discussions about end-of-life care is really important, not just for the patient, but also for their families. It enables them to stay in control of situations when things can really feel quite out of control at this time. For some patients, it won't be right for them to have these discussions, and it's certainly not something we want to see forced onto patients. But for those patients who do want to be involved in these discussions, it's really helpful to have a structure, and for that reason we have advanced care planning.
It's a useful tool that patients, their families and healthcare professionals can use as a basis for discussions. The choices made on the form are not set in stone. Patients can change their minds. But the form does mean that all the people involved in a patient's care can have access to a record of their wishes.
So this is it. This is our local advanced care planning documentation called Planning Ahead, which brings together a number of standalone documents about planning for the future. First of all, there's the preferred priorities for care, which covers patients' advanced wishes about what they might want towards the end of their lives, things they would want, things they would want to avoid, perhaps where they would want to be cared for, who they would want to be with them, perhaps some details of how they might want to die, perhaps whether they want flowers, music, all that kind of detail is important. There are then forms to complete about making a will, putting their affairs in order, and a little bit about funeral planning and appointing someone to make decisions for them if that's something that's appropriate. The final section is a more legal section, which is about an advanced decision to refuse treatment, whereby patients can specifically refuse certain treatments in defined situations. And that may be appropriate for a small number of patients. Patients can decline treatments, but they can't request certain treatments. So there's quite a lot of difficult information and discussion to be had with patients, and so it's not something to be undertaken lightly or to be rushed into. It's very important to consider who is the best person to have these conversations, and that's usually someone who has the best, most long-standing relationship with someone, and it will vary in different situations who that will be.
I think certainly my role as a specialist nurse and working in the community enables me to sort of have time with patients. I have that luxury of being able to spend time, of not having to sort of dash from one patient to another. And I think people often when they're talking perhaps with GPs or consultants, they may not feel they can address perhaps emotional things or psychological issues.
People feel comfortable with certain types of people, and they'll be happy to talk about those delicate situations with whoever they feel comfortable with, and that can be ourselves, who we are in an ideal situation because we build relationships with patients and we have a bit longer time to spend with the patients. So we are in an ideal situation. But I think it's the district nurses, community matrons, GPs are also in the right position for that as well. It's just having the confidence to approach some of these subjects sometimes.
I think with some people, introducing the idea of looking towards the future and looking at end-of-life care is very difficult, and some people are very reluctant to go there, and I think it is just using communication, looking for sort of little key things that come up in conversation, that then you can sort of identify that perhaps the time is right to start having these discussions.
If health professionals are going to engage these conversations, it's important that they have a good relationship with the patient, and that they have the skills and the communication skills to do that. Now, that is one of the problems in the hospital setting, is that there's little time to develop that close relationship with the patient. In those situations, it's often better for other health professionals, such as the community hospice team or community matrons, to carry on that sort of conversation when the patient's discharged, because they're the people who will have a lot of input with the patients and will develop a good relationship with them.
These initial discussions about end-of-life care are just the start. Often there are a number of discussions that will take place, often over quite a prolonged period of time, with a number of different individuals, healthcare professionals. It's then important that the final decisions that have been made are communicated with all the healthcare professionals that are involved. Otherwise, having those discussions has been useless.
In order to share information about the choices people have made with the wider health community, we're developing an end-of-life register of patients' choices. Information about whether advanced planning has been done and what choices have been made is stored securely online, so that any health professional can quickly check how a patient wishes to be cared for.
That information needs to be available to out-of-hours GP services, community matrons, GP services, hospital teams, A&E departments, palliative care teams. It means that if any crisis arises, these choices are available and up to date for the people who need to see them. It means that the choices can then be respected.
Sharing information about a patient's wishes is vital in helping us to give them the care they would like. But in order to give more people the choice over how they are cared for, we need to identify people who are nearing the end of their lives, and we need to do that at the right time so people have the opportunity to think about their end-of-life care in a measured and considered way. The end-of-life register would allow us to identify people in good time to offer them the chance to plan ahead.
The hospital teams need to be able to identify those patients, maybe who are having repeated admissions for life-threatening diseases, and their consultants feel as if they are coming towards the end of their life with their disease process. I think those are the patients that need to be flagged up with their community carers and their GPs, so that if the situation changes at home, then all people who are involved in their care are aware of what the situation is, and so that the patient's wishes can be respected because everybody is aware of them.
Identifying people who are nearing the end of their lives allows us to offer them the chance to make choices about the care they receive and how and where they'd like to die. Recording those wishes and sharing them means that we are better placed to provide the best quality care as a person has chosen, and ultimately allow them as comfortable and dignified a death as possible.